All right. So likely a good follow-up to the candy discussion is to talk about metformin, which can be used for diabetes. But our focus today is on how to prescribe metformin. So I do recognize we have folks out there who may be more on the primary care, internal medicine side of things, where this may be second nature. There may also be a mix of folks that are a little bit more on the mental health side. This tends to be creeping a little bit more into the mental health side. So one of our back to integrated care things that we talked about was potentially looking at this medication because it is that overlap and kind of just doing a refresher on considerations for appropriate use of metformin. All right, so from an objective standpoint, we're going to list the official indications for metformin. I put this in here, so this is my reminder to include a disclaimer because we also are going to be talking about some off-label uses of metformin. And actually, some of the focus will be a little bit on those off-label uses of metformin. We're going to outline dosing recommendations for two potential uses of metformin. So looking at its use for treatment of type 2 diabetes mellitus, as well as treatment for antipsychotic-induced weight gain, which is off-label. So we'll be looking at dosing recommendations for both. The good news is they actually are fairly closely aligned. We're going to describe the adverse effects that are commonly seen. So commonly seen, I use the threshold of being identified up to about 10% of patients who have been on metformin, and then we'll identify potential benefits of metformin for the treatment of type 2 diabetes mellitus, as well as the off-label utilization of metformin for antipsychotic-induced weight gain. So the way I set this up really was to talk a little bit about the fundamental nature of metformin, and then we'll end with a brief look at a couple clinical trials. So starting with the beginning, so metformin actually is available currently with three particular brand names. So Glucophage, Glucophage XR, and the NEOMED, which is the extended release solution. There had been prior brand names for metformin. Many of them have been discontinued. So those are the three that are currently active, although the vast majority of prescriptions for metformin are filled generically. So we have a couple different formulations, immediate release tablets that come in a number of different strengths. Many of these are film coated. So this is my spoiler for the adverse effects. Some of the adverse effects related to metformin are gastrointestinal, nausea, vomiting, diarrhea tend to be really problematic as patients are starting the metformin. So oftentimes the extended release products are used instead of the immediate release. They are the medication in a matrix. So the metformin is actually attached to a drug delivery polymer. Those are kind of packaged into a different polymer that makes up the rest of the tablet. That's actually these oblong ones right here, and it will dissolve over time. So there is a certain concentration of those little spheres of medication that can be released. And it can be released after the medication has gotten through the belly. So that may be one of the reasons why we see a little less nausea and vomiting with it. We still can see some diarrhea if it's taken, because it can be taken once daily. If it's taken later in the day with a larger meal, something like dinner, it's possible that the patient will sleep through some of those adverse effects. So even if they are nauseous, they won't feel so nauseous, and it is possible that they may be able to manage some of those adverse effects a little bit better. The solution is available, so it's 500 milligrams per 5 mLs for some of the larger doses, so that would be 10 mLs twice a day for the up to the maximum of 2,000 milligrams. Again, can cause some gastrointestinal effects, so often taking that with food can be really beneficial for that. I'm focusing just on metformin, not on any of the combination products, if any of you are looking for those. Officially, indication-wise, it is approved for treatment of type 2 diabetes mellitus, so the non-insulin dependent form, but it's being used increasingly for a number of other off-label indications. One of the common ones that I thought would be relevant to this particular audience is the antipsychotic-induced weight gain. Interestingly, there's some data both on prevention of weight gain, which I was probably one of the main skeptics for, as well as treatment. We're going to look at an overall meta-analysis that kind of combined a little bit of that information. But using it before patients gain weight, it does appear to reduce the amount of weight that they gain while they're on antipsychotic medications, specifically second generation. Or in other instances, when it's added on board after a patient has already gained weight. So we can see it increasingly used in both of those areas. It still has the most data for antipsychotic-induced weight gain, but the GLP-1 agonists are closing in quickly. They are definitely targeting this particular population. So this will likely be overtaken within the next year, if not few months, in terms of the amount of literature we have for evidence by the GLP-1. So still a potential option, but we're much more likely to see some of those other treatment options first. Other places metformin may be used off-label. So prevention of type 2 diabetes mellitus, so your pre-diabetes patients, so those who may have risk factors, they have some glucose intolerance, but haven't quite hit that threshold for official diagnosis. My husband actually falls into this category. So really trying to use this to delay or hopefully prevent the full-blown diagnosis of diabetes. So trying to catch things ahead of time and provide some protection and benefit there. It's been used for gestational diabetes. It's been used for patients who have polycystic ovary syndrome, so PCOS, specifically for their ovarian hyperstimulation syndrome. So trying to prevent some of those symptoms. There were a couple other places that it was used as I was going through the general literature. So there had been some discussion about its use in the oncology realm. So there's some lab work being done looking at metformin's use to try to contain the growth of tumor cells, specifically solid tumors. It also has been looked at for some infectious diseases, specifically some of the antivirals. Again, that's much more on the in vitro side of things, so looking at it in the lab, but it surprised me a little bit to see how far off-label this is being looked at. So it's being looked at in a number of different places. All right, so if we decide that we're going to use this product, looking at our dosing recommendations, for the most part, we can start the same, regardless of if the treatment is for type 2 diabetes or if it's for antipsychotic-induced weight gain, which is off-label. Starting with the immediate release tablets, 500 milligrams once a day if somebody is worried about some of those adverse effects. In some cases, they'll try to crack it in half and use 250 milligrams once daily. Again, just trying to manage those gastrointestinal effects. In other cases, it could be started as high as either 500 twice daily or 850 milligrams once daily. Again, from a tolerability perspective, that really is kind of the snag. Not only for patients who have type 2 diabetes, but definitely for the use in antipsychotic-induced weight gain. So if I'm using something for weight gain and I feel like crap when I start it, that's where we see some of the discontinuation. So really trying to start on the lower end for the antipsychotic-induced weight gain would be beneficial. We can then titrate. So titration is recommended for the immediate release products by 500 up to 850 milligrams daily. So increasing essentially just by one of those at least once a week, although the range could be titrating it not once a week, waiting a couple weeks, waiting a month. If the patient had trouble tolerating it, they may not be ready. They just got rid of those gastrointestinal effects and have been feeling better for a couple days. They don't want them back by increasing it the next week. So it is possible to delay that. That would be the fastest titration that they're looking for, at least in the published literature. Maintenance for diabetes can be between 850 and 1,000 milligrams twice daily. The maximum dose that's been used and that's recommended is 2,550. So that's actually the 850 given 3 times daily, or 2 of them at once, and then in one dose and 1 850 in the second dose. For patients who are using this for antipsychotic induced weight gain, there's not been a we don't have enough information to say that there's a clear dose response. So oftentimes you'll see folks that may be on slightly lower doses than what you see for type 2 diabetes. For type 2 diabetes, they do tend to be maximized. We try to get them to the highest tolerable dose, mainly because it can not only help with glucose control, it can help with cardiovascular risk, and it reduces mortality in some clinical trials. So we really want to make sure that we've optimized it, whereas those adverse effects and tolerability may be problematic for the other population, and we don't really have great evidence to say that the higher doses give us more weight loss, at least not yet. On the extended release, so this is once daily, so that tolerability piece may be much better. It is recommended to increase just by 500 milligrams every day, no faster than once a week. Maintenance, it has a little bit of a broader range. It really is recommended to be using some of those higher doses for the extended release preparations, and the maximum dose for that is 2,000 milligrams, likely because that's one of the at that point they can just use the 1,000 milligram, and we're not having to use multiple different strengths of medications. So if that's how we use it, how can the body process it? So it's fairly bioavailable. So 50 to 60% of the dose is actually absorbed. We can see an onset of effect specifically related to type 2 diabetes. So an effect on the sugar as early as about an hour and a half to 2 hours after ingestion. So those actions are going to kick in relatively quickly, although there are some actions that are going to take a longer period of time. It is not protein bound. It is very hydrophilic, so it likes the water. It will over time be picked up by the red blood cells. So the erythrocytes do tend to carry around some of the metformin for patients that have been on it for a longer period of time, which is going to influence our half-life just a smidge. Because it likes the water, it doesn't like going through those membranes. So once it's in a cell, it tends to stay in a cell until it gets pulled out. So that's why we'll see that difference. Time to peak, immediate release tablets, 2 to 3 hours, extended release, that's 6 to 8 hours. So again, if they take it in the evening, that's going to peak while they're sleeping. So they may not notice as much of those adverse effects as they will if they're taking an immediate release product 2 to 3 hours later, maybe right before lunchtime for them. And then the suspension kind of hits right there in the middle between the immediate release and extended release, with time to peak between 3 and about 7 hours. It is not hepatically metabolized. It is renally eliminated, and most of it is renally eliminated unchanged. So we're not seeing any processing. The body's just able to secrete it. Half-life is about 4 to 9 hours. So if we're thinking about how long does it take them to get to steady state, it's going to be a couple days. So 2 to 3 days, they should be at their new steady state. And then at that point, we can see if they're able to tolerate where they're at. As patients continue to use it, there have been reports that if you're looking at the half-life in the blood, it can be up to 17 hours. And again, that's because that metformin is now inside some of those red blood cells, and it's hard to get it out so that it can be kicked out by the kidneys. So in some cases, you can see that go up pretty significantly. It's not routinely recommended to draw serum concentrations. If you do have a patient that has some renal impairment, you may want to do that just to kind of check and see where they're falling, especially if we're getting a little bit nervous about adverse effects. We'll talk about one of the main ones here in just a second. Kidneys get rid of it. And again, it's not just being filtered, but it's actively being secreted. So the elimination of metformin is actually 3.5 times the creatinine clearance. So the normal kidney function measure, we're actually looking at significantly higher for the removal of metformin. But one of the problems that we can run into is the fact that especially if the kidneys aren't working, it does increase the risk for lactic acidosis. So here's a little fun fact for you. So metformin type compounds have been around since the 18th century. So they were actually used as part of, there was a plant that was used in Europe, Galega officinalis, and it has the chemical structure that essentially was derived into metformin. There were three products that were produced, fenformin, buformin, and metformin. Fenformin and buformin both were immediately removed from use because of lactic acidosis. Metformin actually didn't have as much of it, but it still pops up. So this is a black box warning for the product. We want to be watching for any adverse effects. Abdominal pain, which is a problem because they get nausea, vomiting, constipation when they start this. So does that go away? Do they also have malaise? Do they have muscle pain? Do they have excessive somnolence? Do they start having respiratory distress? Then we're going to need to do some extra interventions. If they have lactic acidosis, we discontinue the metformin. They need to be admitted to the hospital for supportive management, and they may likely need to be put on dialysis to help get rid of the metformin as quickly as possible. There have been deaths with metformin use associated with lactic acidosis, so definitely something that we want to be mindful of. People that are at the highest risk for this are those that are over the age of 65, if they have excessive alcohol intake, hepatic impairment, if they have hypoxic states, including things like uncontrolled congestive heart failure, if they're on other medications that may make the patient trend toward acidosis, things like carbonic anhydrase inhibitors. Acetazolamide is one, but zonisamide, topiramate would be other examples. Metformin should be held if a patient's going to undergo a radiological study with contrast. So the contrast can be a little bit harsh on the kidneys. So it is recommended that we hold the doses of metformin until after they've had it and they get themselves well hydrated and their kidneys back to full functioning. Same for the surgical procedure. So with the concern about there being some impairment to the renal elimination, really holding it during the surgical procedures, and then with any renal impairment. So we're not wanting to use this in women who have a serum creatinine less than 1.4, the men who have a serum creatinine less than 1.5, which tends to translate into an estimated kidney function, glomerular filtration rate of less than 30. So if they are less than 30, we are no longer using metformin. That's the big one. Other contraindications are hypersensitivity. Obviously, if they're allergic to it, we don't want to be using it. And then if they have acute or chronic metabolic acidosis, so if they have other conditions on board, diabetic ketoacidosis was the main one that was called out in most of the tertiary literature. We want to be really, really cautious. If they continue to be acidotic, we're not going to be using the metformin because that does put them at risk. So thankfully, that's not a huge cohort of the potential population. And there's a lot of people who can derive significant benefit. So how does this work and why would we do anything with this? So it decreases intestinal glucose absorption. So we're not going to see as much glucose getting absorbed from the foods that a person is ingesting. That may be part of why we end up, if there's more glucose there, there may be more water that ends up in the intestines. That may be what leads us to the diarrhea when they first start this medication. It can decrease hepatic glucose production, so your liver's not making as much glucose as it was before. In some patients, both those with the antipsychotic induced weight gain and those with type 2 diabetes, the liver is just turned on to make extra glucose, even if the body has glucose available. Sometimes that's because they're not sensitive to the insulin. So it's going to shut off this extra source of glucose to help lower some of those sugar levels. That may also help with some of the weight. The last piece is it can improve glucose uptake. So it actually is involved with a number of different signaling cascades that I don't have time to go into in just this brief didactic. But one of the signaling cascades is it does increase the glucose transporter. So there's more transporters to pull the glucose in to things like the skeletal muscle, so in the periphery, so that they're actually using the sugar that's available for them as fuel. And it also can increase some of the sensitivity so that the peripheral tissues are seeing the insulin and they're able to use the sugar that's there and available. Again, that can help with both sugar control and diabetes and with potentially some of the antipsychotic induced weight gain. They're also looking at its actions in a number of other places. As I mentioned, it has some, so the signaling cascade is pretty significant. Some of the signaling cascades, depending on the concentration, so a low concentration may turn certain enzymes on. A high concentration may turn some enzymes off, or vice versa. And it's those changes in concentration that they're looking at for treatment of oncology, those solid tumors. So in some cases, at different concentrations, they're actually able to induce apoptosis in those malignant cells. So those are some of the more detailed, nuanced things that they're looking at related to its actions. So if that's the way that it's working, I already spoiled it with the gastrointestinal effects. So these are the side effects that we're seeing most frequently with the clinical trials. This came right from the prescriber information. So nausea, vomiting, diarrhea, probably not a surprise. Flatulence, also problematic, so that GI system being involved. Asthenia, indigestion, abdominal discomfort, and headache. These all happen in more than 5% of patients and significantly more than the placebo-treated patients. They also tended to be temporary. So these did tend to resolve over time as patients continued to take the medication. That's not all of the adverse effects. So those were the ones captured in the prescribing information. I was a little disappointed we didn't see a more robust list because there's a few other things I counsel patients on when I talk to them about this. So the asthenia and the chest discomfort, asthenia showed up in both places. Patients can develop things like chills and myalgias. So myalgias potentially being a signal of that lactic acidosis. So we do want to pay attention if they say that their muscles are sore. They may develop diaphoresis, so they're sweating. Dizziness actually is one of the main gastrointestinal effects, and dizziness tend to be some of the main causes of discontinuation in the clinical trials. So patients stop taking their medication because they feel dizzy. So that is one that, again, if we start low and slowly titrate up, they can develop a tolerance to. So flushing, headache as a potential issue. The nail disorders, I'm looking for my notes on this one. So this one, I did do a little bit of a deeper dive in. So patients who are older, so those over the age of 60, it happens more in men than in women, and it happens more in patients who have other dermatologic conditions, specifically psoriasis. It can be a number of different things with their nails. So a change in shape, a change in texture. So maybe they get thicker, maybe they're more fragile, maybe they're friable. So they're starting to kind of almost disintegrate, especially on the edges. The tissue around them can become problematic, and the pigment may change. So there's a number of different things that may happen. There are several case reports out in the literature. This tends to be when patients have been on the medicine for a longer period of time. They've discontinued the metformin, the nails get better, they restart it, re-challenge, and that happens again. So just something to be mindful of if patients are starting to have trouble with that. Palpitations don't tend to result in additional cardiovascular effects, but may happen initially. Taste disturbances. So this tends to be fairly common, a little bit higher prevalence with immediate release versus the extended release, but it tends to be like a metallic taste that patients talk about. So if they take it with food, if they have the extended release product, that may be a little bit less, especially if patients are sensitive to that. And the other adverse effect, which was the main one I was looking for when I pulled that list of adverse effects, is the vitamin B12 deficiency. So chronic use of metformin can result in vitamin B12 deficiency, which may then result in megaloblastic anemia. So we don't want to put patients at risk. So that would be something just to be mindful of, making sure that we're monitoring for that and potentially even supplementing that, a multivitamin or even a B12 supplement. So I told you all the bad so far. So why would we even use this? So I'm just going to look briefly at these two clinical trials. So the first one is focused on treatment of diabetes. So double-blind placebo-controlled trial, patients who were had obesity and type 2 diabetes that couldn't control their sugar levels with just dietary management. They were randomized to metformin or placebo, and they took it for up to 29 weeks. They could be titrated, dose titrated. They could go up to 2,550 milligrams of metformin if they needed to. What they found was a significant improvement. So they saw a reduction of an average of 53 milligrams per deciliter of the fasting plasma glucose, and they saw a reduction of almost 1.5 in the hemoglobin A1C. So that picture, that 3-month picture of how much sugar tends to be out in the blood. So this really was one of the landmark trials that helped ensure that metformin was approved for treatment of diabetes. So definitely effective. It's nice because it doesn't tend to cause hypoglycemia in patients. And if they can get through those GI effects initially, they do tend to tolerate it relatively well long term. So what about one of the other places that you may see it? So I just wanted to look briefly at the clinical benefit for antipsychotic-induced weight gain. So this was a meta-analysis that was done. They looked specifically at randomized double-blind trials that were evaluating metformin versus placebo for antipsychotic-induced weight gain. There are several that are cross-sectional trials, that are open-label trials, that do have some potential bias introduced. So they really wanted to look just at those that were randomized and double-blind. Their primary outcome was the mean change in weight and what they saw. So the average duration of the 12 clinical trials was 16 weeks, so about 4 months. And over those 4 months, those patients that were on metformin had an average weight reduction of minus 3.27 kilograms. So 6 to 7 pounds that they saw a reduction over the course of 4 months. They saw a reduction in BMI of just more than 1 point. And they also saw a reduction in the insulin resistance index. So they saw improvements in most of the metabolic features across the board in patients that were on metformin. So that did look to be beneficial. Interestingly, for a diabetes-approved medication, they did not find a statistically significant difference in fasting blood sugar. The confidence interval was relatively broad, and there were quite a few fluctuations within that patient population. So the mean difference was a reduction in the fasting blood sugar, but that wasn't statistically significant just because of how wide that confidence interval was. Likely they needed more patients to be able to demonstrate that. So metformin can be utilized for a number of populations. It may be very beneficial. We got to watch for those adverse effects. We want to make sure it's working for whatever it is that they're using it for. So weight or glucose, make sure we're checking those things. And then just another consideration on the monitoring side, renal function, definitely a baseline, and then at least yearly to make sure nothing has changed. If we see new symptoms pop up, they have edema, something else has changed, then we definitely want to be checking that renal function and the complete blood count, specifically because of the risk for vitamin B12 deficiency. So very commonly utilized medication. It is always in the top 300 of medications that we have our pharmacy students learn. The adverse effects are problematic, but they can be managed. And I think it's important for patients to realize that, because the adverse effects are going to be problematic initially, but most of the benefit that we're going to see for the conditions we use this for are going to be seen more chronically. So they likely aren't going to fully appreciate how much this is helping until they get 2, 3, 4 months down the line. So that was my refresher on metformin. Stop my share and turn it back over to Nicole.